Good morning, everyone. Today I am here to present my seminar on the topic of obsessive compulsive spectrum, and my moderator is Dr. Shobit Garg sir. What is obsessive compulsive disorder? Obsessions are intrusive and unwanted, repetitive thoughts, urges, or impulses that often leads to a marked increase in anxiety or distress. And compulsions are repetitive behaviors or mental acts that are done in response to obsessions or in a rigid, rule-bound way. And compulsions can be obsession and compulsions can be time consuming and interfere significantly with the person's routine, occupational functioning, usual social activities or relationships. OCD has four major symptoms pattern, of which contamination or cleansing is the most common pattern. In this, there is obsession of contamination followed by washing or accompanied by compulsive avoidance of the presumably contaminated object. And anxiety is the most common emotional response to the fear object. Number second is the obsession of doubt, followed by the compulsion of checking. It is also associated with feeling of guilt about having forgotten or committed something. Obsession often implies danger of violence, for example, forgetting to turn off the stove or not locking a door. Number third is intrusive or forbidden thought, intrusive obsessional thoughts without a compulsion. Patients usually experience thoughts of a sexual or aggressive act that is reprehensible to the patient, may report themselves to the police or confess to a priest. Sir, there was a patient in OPD. Sir, he said कि मैं बार बार किसी भी रैंडम लड़की को देखता हूँ तो मेरे दिमाग में ऐसे सेक्सुअल और एग्रेसिव थॉट्स आते हैं. So that can be example of intrusive or forbidden thought. Number fourth is symmetry or ordering can lead to a compulsion of slowness. Patient can take hours to eat a meal or shave their faces. Etiology. It is a neuropsychiatric disorder that is mediated by specific neurocircuits. Earlier, it was established that OCD could be precipitated by damage to the striatal circuitry. Brain regions which are involved in OCD are anterior cingulate and orbitofrontal cortex and striatum. Corticostriatal thalamic cortical circuitry has also important role in mediating cognitive affective impairments in OCD. Important neurotransmitters involved in OCD are serotonin, dopamine, glutamate, and GABA. There is also role of genetic susceptibility in OCD. Epidemiology. Lifetime prevalence in general population is 2 to 3%. According to community studies, there is higher prevalence in females, and according to clinical context, there is roughly equal numbers of males and females affected. Mean age of onset is 19 years. Early onset most common in male, and OCD is rare after 30 years of age. Associated comorbidities, of which major depressive disorder is the most common. Number second is the social phobia. Suicide is also a risk. Other comorbidities associated are alcohol use disorder, generalized anxiety disorder, specific phobia, panic disorder, eating disorder, personality disorders like OCPD. Incidence of Tourette syndrome is 5 to 7% and 20 to 30% have a history of TIC. Diagnostic criteria for OCD. According to DSM-5, obsessions or compulsions should be present. According to DSM-5, obsessions are intrusive thoughts that accompany behaviors and that individuals may attempt to ignore or counteract through action. And compulsion is repetitive actions commonly driven by an obsessive thought performed to relieve anxiety or fear. Symptoms and behavior must consume at least 1 hour throughout the day of the patient or cause significant distress and impairment. It is further classified as tic related with good or fair insight, with poor insight, or with absent insight or delusional belief, in which strong conviction that beliefs surrounding the actions are true. According to ICD-10, recurrent obsessional thoughts and or compulsive acts should be present. Obsessions are ideas, images, or impulses occurring recurrently, and compulsions are repetitive stereotype behaviors meant to neutralize a thought or anxiety or prevent a perceived adverse event. Attempts at resisting thoughts and behaviors are frequently unsuccessful and cause worsening anxiety. Predominantly obsessional thoughts or ruminations are present, and predominantly compulsive acts, that is obsessional rituals, are present, or mixed obsessional thoughts and acts. According to ICD-11, features like obsession and compulsion must most commonly both are present. And in this also, obsessions and compulsion symptoms and behaviors should consume more than 1 hour per day It is further classified into obsessive compulsive disorder with fair to good insight, obsessive compulsive disorder with poor to absent insight, and obsessive compulsive disorder unspecified. Treatment. We will study the treatment under the following headings: first line drugs, second line drugs, experimental drugs, psychotherapy, and somatic therapies. Somatic therapies include anterior cingulotomy and capsulotomy, deep brain stimulation, and transcranial magnetic stimulation. Role of psychotherapy in patients of OCD, of which most effective is the exposure and response prevention, which minimizes the avoidance of the distressing cues, encourage in vivo exposure to feared situations, imaginal exposure to feared consequences, replace distortions with more adaptive thinking patterns, mindfulness techniques, and family sessions. PCT does not seem to play a useful role in the OCD patients. First line treatment, we can use SSRIs. Doses for OCD are usually higher than that for the depression. Fluoxetine can be given up to 60 mg and paroxetine up to 40 to 60 mg. Effect in 12 weeks. Treatment should continue for at least 1 year. The second first line drug we can use is clomipramine. Oral dose is 250 mg and IV we can give 40 mg per ml injection up to 80 mg. Pulse loading doses of IV clomipramine produces rapid decrease in symptoms. Treatment resistance OCT with oral clomipramine. Second line is we can add antipsychotics to SSRIs. Low moderate doses of SSRIs के साथ हम add कर सकते हैं. Risperidone, aripiprazole. There is also some evidence that we can use haloperidol. Second line drug we can use is citalopram. 40 mg with clomipramine we can give. Third we can use acetylcysteine up to 2400 milligrams per day, and we can also give lamotrigine and topiramate. Experimental treatment, we have used escitalopram, sertraline, celecoxib, venlafaxine, intravenous ketamine, and morphine up to 15 to 45 mg. Second is the body dysmorphic disorder. In body dysmorphic disorder, there is persistent preoccupation about one or more perceived defects or flaws in one's appearance. Concerns about their appearance result in a range of mental acts or behaviors, including comparing themselves with others, checking in the mirror, or camouflaging their perceived flaws. Most common concerns involve the face and the head, and mostly the skin, nose shape, size, and hair. Commonly associated symptoms include ideas or delusion of reference. Patient will check mirror frequently or avoid the reflective surfaces. The ideas or delusion of reference are also about others noting their alleged flaw. Body dysmorphic disorder has less insight in comparison to the patients with OCD. Etiology. There is deficit in the there can be seen the deficit in the executive functioning or visual processing. Corticospinal thalamic cortical circuits may be involved, and there is also role of genetic susceptibility. According to epidemiology, there is higher prevalence in the community studies in female, and according to clinical context, there is roughly equal incidence is roughly equal in males and females. Comorbidities associated with body dysmorphic disorders are depression, suicidality, OCD, panic disorder, which is triggered by appearance concern, and substance use disorder, which patient can self-medicate to relieve the symptoms of social anxiety or emotional pain. According to DSM-5, there should be a preoccupation with the physical appearance and subjective flaws, and presence of repetitive behaviors at some point during the disorder, like checking, grooming, skin picking, recurrent thoughts or perseveration on comparing physical appearance to that of the others. Presence of both of the above criteria is required according to DSM-5, which is further classified as with muscle dysmorphia, with good or fair insight, with poor insight, or with absent insight or delusional beliefs. According to ICD-11, there should be five symptoms should be present related to the body dysmorphic disorder. Onset is not mentioned in this disorder. Body dysmorphic disorder with fair to good insight, with poor or absent insight, or unspecified. According to ICD-10, there should be excessive preoccupation with image or appearance, and there should be significant distress or impairment in the area of the functioning. Treatment of body dysmorphic disorder, cognitive behavioral therapy or SSRIs can be given, or combination of both of them can be given. There is a stepped care model according to the NICE guidelines. Every patient on SSRI should be monitored for development of akathisia, increased anxiety, and emergence of suicidal ideation. Number one step will be guided self-help support. Number two step will be that we will offer CBT, involve family cares. And number third, we will use the pharmacological treatment like SSRIs along with CBT. Consider different SSRIs, and buspirone may fully operate the SSRI. Number third is the hoarding disorder. In this, the patient have persistent and profound difficulty discarding or parting with their possession. Compulsive hoarding is a common and often disabling phenomena associated with impairment in such functions as eating, sleeping, and grooming. There can be injuries from fire or falling. What drives the behavior appears to be the fear of losing items that the patient believes will be needed later, and a distorted belief about or an emotional attachment to possession. Patients perceive their behavior to be reasonable and part of their identity, which is not seen in the body dysmorphic disorder. Most hoarding patients accumulate possessions passively rather than intentionally. Commonly hoarded items can be newspaper, mail, magazines, old clothes, bag, books, lists, and notes. In severe cases, hoarding can interfere with the work, social interaction, and necessary activities such as eating or sleeping. Patients with hoarding disorder also overemphasize the importance of recalling information and possession. For example, a hoarder will keep old newspapers and magazines because they believe that important information may be lost. Etiology: there is impairment in various neuropsychological domains, like there will be impairment in spatial planning, working memory, response inhibition, and set shifting. Research on patients shows that there is also involvement of ventromedial, prefrontal, and anterior cingulate cortical and medial temporal region. In animal studies, there is also seen role of dopaminergic system in hoarding, and genetic susceptibility also plays an important role. Epidemiology: most prevalent studies of hoarding disorder have not used DSM-5 diagnostic criteria. Hoarding disorder remarkably present in the Western countries, but there was one study which employed DSM-5 criteria, yielding a point prevalence of 1.5%. Community studies show equal prevalence in male and females, and in clinical context, there is higher prevalence in females. Prevalence of hoarding increases with age. Other comorbidities can be seen like OCD, generalized anxiety disorder, and major depressive disorder. Diagnostic criteria for hoarding disorder according to DSM-5 is there should be excessive attachment to possessions, distress related to being separated from the items, excessive accumulation of possession. Accumulation results in significant distress, impairment, and or safety health compromise. All of the above symptoms are required. And it is further classified as with excessive acquisition, with good or fair insight, with poor insight, or with absent insight or delusional beliefs. According to ICD-11, hoarding disorder is characterized by accumulation of possession due to excessive acquisition or of difficulty discarding possession, regardless of their actual value. And it is further classified as BDD with fair to good insight, with poor or absent insight. Sorry, sir. Hoarding disorder is characterized by difficulty parting with objects due to perceived needs to save possession, distress, and functional impairment associated with being separated from the possession. Treatment of hoarding disorder. The hoarding disorder is very challenging to treat. Even though similar to OCD, treatments effective for OCD have little effect in hoarding disorder. Pharmacotherapy includes SSRIs, venlafaxine. Challenges include poor insight of the patient, low motivation, resistant to treatment. Most effective treatment is the cognitive behavioral model, which includes training in decision making, categorizing, exposure and rehabilitation to discarding, and cognitive reconstructing. Goal of the treatment is to get rid of the significant amount of possession, make living space livable, and help patients maintain a positive balance. Hair pulling disorder. which is also known as trichotillomania. It is a chronic disorder characterized by repetitive hair pulling, leading to variable hair loss that may be visible to others, which resembles both obsessive compulsive and impulse control disorder. There is increased tension before the hair pulling, which leads to the behavior and then subsequent relief or satisfaction. All areas of the body may be affected. Most commonly, the scalp is affected, and less commonly is the pubic areas which is affected. There are two types of hair pulling: focused pulling or automatic pulling. In focused pulling, there is intentional act to control unpleasant personal experiences. On the other hand, automatic pulling occurs outside the patient's awareness and most often during the sedentary activity. Most patients have a combination of both of these types. Hair loss usually appears as short broken strands near long healthy hairs in the affected areas, and there is no abnormality of skin or scalp seen. Trichophagy, which is mouthing of the hair, may follow the hair plucking. Complications of trichophagy can be trichobezoars, malnutrition, and intestinal obstruction. Patient usually denies the behavior and try to hide the resultant alopecia. Etiology: there is deficit in working memory or visual spatial learning. There is also involvement of corticospinal thalamic cortical circuits, which is relevant to the habit learning, and brain regions which are associated with reward processing and affect regulation. Epidemiology: studies of select population in college students indicate wide prevalence of trichotillomania around 0.5 to 2%. Female is to male ratio is 4:1. Comorbidity: other body focused repetitive behaviors like excoriation disorder, which is most commonly associated with trichotillomania, and OCD and mood and anxiety disorder can also be associated with it. The diagnostic criteria for trichotillomania: according to DSM-5, recurrent hair pulling causing hair loss, hair pulling despite repeated attempts to change or end behavior, actions that cause distress and or impaired functioning. All of the above symptoms should be present. According to ICD-11, hair pulling may occur in brief episodes scattered throughout the day or in less frequent but more sustained periods. And symptoms should result in significant distress or significant impairment in personal, family, social, educational, occupational, or other important areas of function. According to ICD-10, there should be presence of noticeable hair loss due to recurrent hair pulling, and hair pulling behavior preceded by increased anxiety that is relieved by hair pulling. Treatment of trichotillomania: most significant trials are seen with N-acetylcysteine, which can be given up to 1200 to 2400 milligrams per day. And it is used as a first-line therapy for the treatment of trichotillomania. Early data says patients responded to clomipramine, then desipramine. New trials with SSRIs and venlafaxine have not given consistent results, and it is used as a second-line treatment approach. Small trials indicate efficacy of dopamine receptor blockers, but this is kept for treatment-resistant cases as an end-line approach. Habit reversal technique, which is a cognitive behavioral therapy technique, which is efficacious in treatment, usually in children, which includes awareness training, social support, and competing for response training. Excoriation or skin picking disorder. It is in this the patient repeatedly pick their skin sufficiently to cause lesion. While some picking of scabs is universal, in case of excoriation disorder, behavior causes significant distress or impairment. Historical literature describes cases of neurotic excoriation and psychogenic excoriation. However, it was only with DSM that the disorder became a separate diagnosis. Skin picking may be from any area of the body, but is most commonly from the face. And in some cases, there may be requirement of skin grafting or radiosurgery. Patient experiences tension before picking and relief or gratification after picking. Despite the feeling of relief felt from picking, patients often feel guilty or embarrassed at their behavior. In etiology, there is involvement of corticospinal thalamic cortical circuits and dopaminergic system, and there is also role of genetic susceptibility. In epidemiology, mean age of onset is 12%, and it is seen more commonly in females than in males. And most common associated repetitive behavior with excoriation disorder can be hair pulling disorder. Diagnostic criteria. According to DSM-5, there should be recurrent skin picking causing lesion to the skin, ongoing skin picking despite repeated attempts to change or end behaviors, actions cause distress or impaired functioning. All of the above symptoms are required. According to ICD-11, excoriation disorder is characterized by recurrent picking of one's own skin, leading to skin lesions, accompanied by unsuccessful attempt to decrease or stop the behavior. Then, according to ICD-10, diagnostic criteria is similar as that of the OCD. Treatment of excoriation disorder. Now, most patients do not actively seek treatment because they are embarrassed or believe their condition is untreatable. And so SSRIs is used, fluoxetine can be used as a superior effect. Lamotrigine shows inconsistent result. Non-pharmacological treatment can be used like habit reversal technique. Olfactory reflex disorder, which is characterized by persistent preoccupation with the belief that one is emitting a perceived foul or offensive body odor or breath that is either unnoticeable or only slightly noticeable to others. Individuals experience excessive self-consciousness about the perceived odor, often with ideas of reference. In response to their preoccupation, individuals engage in repetitive and excessive behavior, such as repeatedly checking for body odor, checking perceived source of the smell, repeatedly seeking reassurance, excessive attempts to camouflage, alter or prevent the perceived odor, and marked avoidance of the social situation. Symptoms are sufficiently severe to result in significant distress or significant impairment. Further, it is classified as with fair and good insight, poor and absent insight, or unspecified. Differential diagnosis can be pediatric autoimmune neuropsychiatric disorder associated with streptococcus. In this, there is OCD-like symptoms in children following a group A beta hemolytic streptococcal infection. It is an autoimmune process in which there is inflammation of the basal ganglia, which disturb the corticostriatal thalamic axis functioning. Number second is the OCD-like disorders that are associated with basal ganglia disease, like Sydenham-Chorea and Huntington disease. In this, we have to perform a thorough neurological examination to rule out OCD from Sydenham-Chorea and Huntington disease. OCD often develops after age of 30 years, and new onset OCD in an older individual should raise the question of potential neurological contribution to the disorder. Alopecia is also seen in hair plucking disorder, which can be ruled out by biopsy. Biopsy may be necessary to distinguish hair pulling disorder from alopecia areata and tinea capitis. Many dermatological conditions like skin picking, which is seen in scabies due to itching, and Prader-Willi syndrome should also be differentiated. Tourette syndrome, which is associated with OCD, as the two conditions frequently co-occur both in individuals over time and within families. 90% of patients with Tourette disorder have compulsive symptoms, and 2/3 meet the diagnostic criteria for OCD. Patients with Tourette disorder have recurrent vocal and motor tics that bear only a slight resemblance to the OCD. Obsessive, we can differentiate obsessive compulsive disorder with other disorders like obsessive compulsive personality disorder, which is associated with an obsessive concern for details, perfectionism, and other similar personality traits. Only OCD is associated with genuine obsessions and compulsion. Generalized anxiety disorder, worries are about real life concerns, and they tend to be irrational and less irrational and ego dystonic than in OCD. Psychotic symptoms often lead to obsessive thoughts and compulsive behavior, bodily preoccupations, or hoarding behaviors that can be difficult to distinguish from the OCD and related disorder. Patients with psychotic disorders, however, cannot acknowledge the unreasonableness of their behavior. OCD can also be seen in cases of major depression, but we can differentiate it from normal OCD only that OC-like symptoms will be present in major depression during the depressive episode. Avoidant personality disorder or social phobia, worry about being embarrassed by imagined or real defects in appearance, concern not prominent, persistent, distressing, or impairing. Other psychiatric disorder may cause hoarding symptoms, which like autism spectrum disorder, in which the collections of the material may reflect a specific interest, and it can also be seen in psychotic disorder. Only diagnose hoarding disorder if the hoarding symptoms are independent of the other disorder. Neurodevelopmental and neurodegenerative conditions may be associated with hoarding, for example, like Prader-Willi syndrome, characterized by hoarding of food, obesity, and skin picking. Damage to specific brain regions like anterior, ventromedial, prefrontal, and cingulate cortices may cause excessive and indiscriminate hoarding activity. OCD may hoard as a response to an unwanted obsession. Situation is most familiar with obsession around symmetry, incompleteness, or fears of harms or contamination. In contrast, in hoarding disorder, there is no associated obsession. Instead, the individual wishes to retain saved items and distressed by the thought of discarding them. These are my references. Thank you.
So, PubMed is a research engine. It's not a reputation. This NCBI is also an open of PubMed only. Specific articles. Have you inculcated those references which we share?
Yes.
I think Dr. Sarthak had presented OC spectrum. We started with OCD, then went to body dysmorphia, then hoarding, then skin picking, then excoriations, then to differentials, management of each and differentials, and he has closed it. So I've opened the topic for comments, clarifications, and any questions. Very interesting topic. And we do deal with this topic, these kind of patients day in day.
Sir, mostly. Yes, sir.
Any questions? Or your contributions to the substrate? Forms of obsession, various forms of compulsion.
The forms of obsession of contamination.
Your content, the types of obsessions, types of compulsion, which is asking for obsessive idea, image, else, impulse, fear, and doubt. The 5 forms. Anything else? But I think better if you have actually conceptualized from starting. What do you mean in general by OC spectrum? OC spectrum, the first 2, 3, 4, 5, 6. But why they are called as OC spectrum? The general principles of OC spectrum. Oh, yes. Classification. Please share what is the classification. There are a lot of concepts, a lot of spectrums people have come up. What are the general principles of forming those spectrums? These are fine. This is actually a predominantly followed what DSM-5 says. What DSM-5 says the series you are making and why, but उसके पहले चैप्टर में लिखा है DSM-5 के why DSM-5 has clubbed everything under OCD and related disorders. That should have come up in first two slides. That is a basic understanding. So and also when you're comparing it with other diagnosis systems, where are they placed in other diagnosis systems? Was holding placed under the similar headline in DSM-4 or ICD-10 or in some other subsection? Body dysmorphobia, this has been put under OCD and related disorders. Where body dysmorphobia was in ICD-10? Otherwise, it is incomplete. And spectrum, why spectrum in as per phenomenology, she's saying as per neurobiology, it's a spectrum. How it's a spectrum? So I think you need to present it again. Because concept is not very clear. We can read DSM. This is will come in DSM. What is the concept of a spectrum in OCD? Why we are saying everything is related to each other? That is not very clear. Can you share? Because the idea behind giving any spectrum is basic concept of the spectrum. Dr. Veena, you could find anything? Anyone can share why this spectrum, we have clubbed everything together, why? Tasman has given this very clear, as far as I remember. That is why I asked you yesterday, Tasman has given that basic concept of spectrum, how it started and what are the various models of spectrum, and then where each and every disorder lies. Very nice diagram they have. OC spectrum, a big circle, then small circles around it. Any questions, comments? Associated with staphylococcal infection. Or streptococcal infection.
What kind of obsession?
So, OCD-like symptoms in children, like sir, can be sir anything like collecting sir stones or sir anything, any obsession which is present in other disorders, sir.
Can you diagnostic criteria of pandas being shared? What is the diagnostic criteria of pandas? When we diagnose pandas? Throat infection, yes,
Fever, throat infection,
associated with streptococci. Yes. Anything else? Any movement disorder will be there? Tics will be present. New onset tics will be present. And new onset OC symptoms will be there. And then there is an age cutoff also in pandas. Pandas you don't diagnose in 15-year-old. So, and pandas is an obsolete term now. Now this panas. They remove this BA. So pans get and broad category, all these categorized. So basically, obsessions, they're not typically any obsession. Any obsession can. Children don't generally find, they'll not give you those obsessions, it will be more of rituals. You will not be able to access obsessions, compulsive activities. Say, when they grow old, then they are able to report the obsessions. Because cognitive capacity, they actually could report it in the very young, very small children.
obsessive spectrum and clozapine can also use it. Many patients I have seen, they develop obsessive spectrum of clozapine. If so, it is difficult to see if the OC or hepatocytosis. Those patients will not be so coherent as the non-psychotic patients, maybe the spots that they use. So there may be some part of religion also. So you have to see longitudinal linguistics there. The medicine is taking care and clozapine treatment के बहुत पेशेंट को उसे क्या मतलब कोमोrbid पे होता है as it is और ट्रीटमेंट की वजह से भी आता है ट्रीटमेंट वजह से you can know अगर आप ट्रीटमेंट चेंज कर रहे हो and पेशेंट सिम्टम्स कम हो रहा है but the difficult part is clozapine mostly will start when other symptoms are fade तो वहाँ पे options भी कम हो जाते हैं कि पेशेंट्स को फिर आप it is also
comments Srinivas no comments Dr. Veena so we'll have 30 comments Rishal, you should be more fun to do that as well.
Earlier should mandatory appear on this the topic. You should come prepared with a topic. Not a critical, not, but your contribution. You want to add on some information you have. Yes, you have seen that. So, added information. That means,
उसके पढ़ना पड़ेगा we'll do it
yes. So at least you need to go through the topic before coming to this.
क्योंकि ये तो गोल्डन अपॉर्चुनिटीज है यही सब क्वेश्चन आएंगे ये आपने अभी पढ़ लिया तो आपको एग्जाम के लिए अच्छा करना भी पड़ेगा
4 or 5 short body dysmorphia, body disorder.
हम लोग खेल रहे हैं वही थ्योरी क्वेश्चन
that in the spectrum of the disorders, this share similar equality like the concept of obsession, biology, similar concept.
So impulse, compulsive spectrum. Compulsive spectrum should have.
That they are able to
So, some are in compulsive spectrum, some are in impulsive spectrum. Your interns would have understood it. What is the conclusion?
You want to ask or you are telling something?
You tell, no? Share the similarity.
Does it come in spectrum?
Can we diagnose OCD with poor insight in a patient from onset? Illness onset has started with OCD, like 5 years of OCD, but since the initiation patient is having poor insight, can we diagnose OCD with poor insight in these kind of patients? What is the diagnosis system says? तो diagnostic DSM पढ़ोगे OCD में उसमें लिखा हुआ है. So initial DSM-4 and ICD, they used to tell DSM-4 was very clear. You can't diagnose OCD with poor insight without prior diagnosis of OCD with good insight, fair insight. उसके बाद insight loss होगा, then you can diagnose. But DSM-5 says now you can diagnose patients with OCD with poor insight from initiation. ठीक है डॉक्टर संजीव जी?
As presentation by OCD itself is a long list. So उसमें अलग से अलग starting from like the pathophysiology, sex mechanisms, or the personality, what kind of parenting we could do. So OCD itself is a okay, but that's happening. Also the most distressing for the patient also. Like I think in GAD से ज़्यादा patient को OCD से distress होता है. तो उस हिसाब से भी काफी important है.
So I'll just first give my comment before you, sir, that you have worked hard, but you would have actually shared your presentation little early. You could have walked it around and made it even more better than last week. So and then it would have actually given the audience much more good flow of information. So starting is little abrupt, ending is also abrupt. Then what are the take-home messages? Initially, presentation should start with the outline of the presentation. I'm going to say this in the presentation, and then it ends with take-home messages. There is a basic of the presentation, and then irrelevant details you can always filter. The presentation should be a flow of a set of ideas which you want to actually impart to the audience. So everything need not be put up in the presentation. So for this, you need to actually come up to your moderators at least a week before ready presentations. एक दिन पहले नहीं हो पाएगा. If we'll give you contribute, if we'll tell you so many things, you will have a nervous breakdown a day before if you will modify those presentations. So that is one thing, and always references needs to be asked. If you can ask anyone. So I think you can later on present like what are the basics in a group discussion in spontaneous manner. Need not prepare reports. What is the basic?
See, there are different expectations. GR1, we have different expectations, then this is good for writing short notes. And it goes beyond just earning the diagnostic criteria. Diagnostic criteria are not less. The concept is how we are connected with the basic. As your yourself written the ICD-10, ICD-11, DSM-5, they are different. So what actually we are talking about? The way the presentation is about the disorder and the OCD spectrum. In clinical sense, you will find patients, but they don't really come with the spectrum disorder per se. Like you may find trichosyndrome, like a patient in depression, or from dermatology, they may have for alopecia, they may come for treatment. So in that case, or in psychosis, you may sometimes find the symptoms. There is a very high rate of morbid. So in management, we should not lose focus. Sometimes we use focus like severe depression with patient has found the trichotina. So the focus is depression, okay, or whatever is there. And most of the patients who you come across may be well balanced. So unnecessary if you're trying to treat those symptoms. That would be like coding. Many people like they are coding, but it is not like disorder in the sense that it is not impairing. So in that case, we know like they may be brought by their spouse or something. So you need to assess the how much impact it is having before you start treating. That is the.
Thank you.